So today what I'm covering schizophrenia, BPAD, lithium. Okay. Harneet got question about lithium. I don't know if she mentioned that. She was talking something about inotropes. But yeah, she did get a question on lithium.
Lithium toxicity and digoxin.
Okay. So I remember her calling me on December 25th or something, January 25th or something, asking me, okay, I'm studying all this, but what is lithium and sports? What is lithium and dehydration? She didn't understand. So I am going to cover that topic today. So please pay attention. Okay. And okay. I think I wrote part 5 in the last lecture for February 6th. I was just looking at it and I realized that I'm sorry about that.
It's
Okay.
just in the video.
Sorry, Jagru. Oh, it's just in the video?
Yeah.
Okay. Thank you, Jagru. Okay, good. All right. So schizophrenia, what is the definition of the word schizophrenia? Schizo actually, if you research what is the definition of schizo means split. And phrenia is referred to mind. Okay. So splitting of mind, but it doesn't mean splitting personality, like dissociative personality, that a person has two personalities. That's not what it is. Schizophrenia is a thought process disorder. So how many of you have seen the video of the guy in the blue shirt, the purple shirt, the young guy? Do you guys remember his video? Any one of you? No?
Yes.
Yeah? Mandeep, what do you remember about him? Jagru?
Like he's feeling like somebody's monitoring him and
Okay.
they will harm him.
Yeah. So he was paranoid?
Yeah.
Yeah. He's like, I don't know. And then he also mentioned one of the things that I smoke a little bit of weed.
Yeah, but I didn't understand like what is that.
I know. Weed is pung, marijuana, which is legal in Canada. Okay. So there is a relationship of some of the recreational drugs with schizophrenia, and I will mention that too. I will let you guys know. It's very important to know because now it's legalized. So it's even more important. So the background, it's a thought process disorder. How your brain processes the thoughts, that's what this disorder is. So sometimes patient has looseness of association, derailment. Derailment means the patient is talking about one thing, but then they derail from one thing to another thing. They go from one to, this is also known as loose associations. I'm going to cover that too. It's characterized by disorganized speech due to lack of connection between ideas. Key symptom of schizophrenia, they are positive and negative, and I'm going to cover them in detail. This is just a picture of that. How do you diagnose the patient? Of course, first of all, it's behavior. Either the family tells you this guy's mom told him to go see the doctor, right? So behavior is different. Personality has changed. Thought processes, because his thought process, he has delusion of persecution or persecutory delusion that somebody's out there to kill me. Cognitive abilities, is he able to focus and concentrate? Identify any disturbances. So any of the disturbances in the above criteria is actually a diagnostic of schizophrenia. So when we call spectrum, what is the meaning of the word spectrum? So spectrum means a scale. Okay. Anytime you see spectrum, it means a scale. When they say broad spectrum antibiotics, that means there is a scale and you can use these drugs on all these various scales. So schizophrenia has phases. Pre-morbid is like normal functioning. Symptoms have not become apparent yet. Pre-morbid, before it even is evident. Next is prodromal. Have you guys heard about the prodromal phase of diseases? That some of the diseases are infectious when the patient is prodromal. Write down this word. You may need to find out the meaning. So prodromal just means that you see the subclinic. So for example, you guys had COVID, right? The nurse calls you and asks you, when did you first start having symptoms, right? And then they say 48 hours, within those 48 hours, initially, when you started having symptoms, who all did you meet? Okay, that is the prodromal phase. So for example, the first subclinical symptom to actual clinical symptom is the prodromal phase. In this one, prodromal phase is like the disease has not fully come out, but there is like it has started, but it's not out there. It may take a long period of time, months to years, for that disease to come out. They're never going to ask you these things, but it's good for your understanding that prodromal, pre-morbid, normal functioning. Prodromal, a little like tempered, meaning like little lighter form of the disorder, that the person showing one or two signs, but you can't really tell what's going on. Okay. Schizophrenia, of course, like the positive symptoms are noticeable and apparent. And I'm going to go over what are the positive symptoms. Residual ones, residual means period of remission. Schizophrenia also has a period of remission when the patient is on medications, they are doing fine, they are stable. And then there's a period of remission that schizophrenia is not up there. The person is deluded, hallucinating, and all of a sudden now they're calm. Okay. Negative symptoms may remain, but sign and symptoms of the acute stage, which is positive symptoms, are gone. So now, acute stage, positive symptoms. What are positive symptoms? What are negative symptoms of schizophrenia? Whole schizophrenia is framed around positive and negative symptoms. Positive symptoms meaning something is extra. Okay. So the word meaning positive does not mean those things are positive. Positive meaning that something is extra in the patient. Negative meaning that something is absent. Okay. So if you want to do positive, negative, think about plus and minus. Plus mean extra things for the patient. Minus means some of the things which are normal are not there in the patient. So for example, if you think about positive, delusions and hallucinations, what do you guys think extra? Not a normal person's people don't need delusions and hallucinations, right? Positive, extra symptoms. Anxiety or agitation. This guy who came was very anxious and agitated. Auditory hallucinations, most common in schizophrenia. That's why we are always assessing auditory hallucinations, right? Jumbled speech. Speech is not the way it should be. Their speech is not correct. They may be saying words like neologism. They make new words. They have word salad. They will have clang associations, and I will go over what those things are. Disorganized behavior. Now, negative is absent, flat affect, like no emotion, like the face is just blank, lack of energy, reduced speech. Now, everything is negative, is low, 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 right? Reduced evolution. We talked about evolution, lack of motivation. Okay. So evolution is, and I think we talked about evolution and anhedonia. Lack of pleasure, the activities, if the guy liked to play ice hockey, but now all of a sudden he doesn't like it, is anhedonia. Lack of social interaction. So schizophrenia has positive signs, negative signs, and the social factor is a very important factor for schizophrenia to be diagnosed. Okay. Causes possibly, but they don't know exactly what are the cause, but they're thinking that maybe because the positive symptoms are signs and symptoms of acute stage. Okay. How would you know, like if you just have the negative symptoms, what are you going to think? Maybe the person has depression, right? But if you look at the positive symptoms, that you think, oh my God, the person is in psychosis, it could be schizophrenia. Okay. So when you are very, I mentioned to dose, again, I'm mentioning dopamine, oxytocin, serotonin, and epinephrine. These are good, like energy, mood lifting, or energy giving neurotransmitters. So in this one, schizophrenia, they think maybe increase in dopamine could be one of the causes. Illicit substances. So now group marijuana is actually the drug, the weed I'm talking about. Okay. Environmental factors can also play a role, like the toxin, malnutrition, or sometimes the virus during pregnancy can cause schizophrenia too. Genetics, of course, we talked about the family history. What is the treatment? Treatment is antipsychotic medications, because the person is in psychosis, antipsychotic. Why antidepressants? Because the person has negative symptoms. Okay. Mood stabilizers, you want to stabilize the mood of the person. Benzodiazepines, what is written under, we have covered that already. Therapy and exercise. Okay. Nursing consideration, the very first thing with schizophrenia patient is trust. In fact, all the mental health patient trust in building rapport. Schizophrenia patient especially, why do you think you need to build a trust with the client? Because they can have paranoid delusions, right? The guy who came to see the physician was paranoid that his friends are going to kill him. They are involved in MI5. So the first thing as a nurse you need is trust. Okay. Encourage compliance with the medications. Promote self-care. They may not have any interest in taking care of themselves. Okay. Encourage group activities. In the acute stage, it's very hard to encourage the group activities, especially with a paranoid client. Why? Navjot, why it's hard for a paranoid client to be in group activity?
Because of lack of interest, lack of trust.
Lack of trust, yeah. They can't sit with other people. They don't like other people. So you may not want to involve them in group activities. You may want to start them with solitary activities so that they can build the trust with the nurse first. And when their disease conditions start improving, that's when you have to put them in group activities. It's very important to put them in group activities once they stabilize, the reason being because impaired social interaction is one of the nursing diagnoses. Okay, schizophrenia and social interaction gets impaired because they are paranoid or their thought process is loose. They're having loose associations and people don't, they don't trust people. They don't want to be around people. But we have to bring it, like we always, our goal is to bring the patient back to the level of functioning, right? Offer therapeutic communication. And I have covered all this, how to address hallucinations. So I'm going to go forward, but you guys still have this slide. Okay. Again, this is from UWorld, positive and negative symptoms. You guys are gonna get questions on positive and negative symptoms. If you look at positive, just like I mentioned, positive means extra. Positive does not mean something good. Positive is pathological excesses. You don't need it in excess, but it's there. And negative means deficit. Okay, you're lacking something. So anytime there's a lack, it will be a negative. Lack of motivation, apathy. Lack of motivation is evolution. I think they wrote it. This is not right. Social withdrawal, I mentioned this. Social withdrawal is so important. Flat affect, emotional flattening, monotone speech, poverty of speech. But we talked about incoherent speech. Where would that go? The group.
Sorry?
Incoherent speech, when the speech is disorganized, where would that go? Would that be negative or positive?
Negative.
Positive.
Positive. It's on the screen too. Look. Okay. Lack of speech. The patient will become mute. Schizophrenia patients come and they don't talk to you for so long. We had a schizophrenia patient who thought she was married to Jesus Christ and was mute. She was mute. She would not utter a single word. And nobody, and you would think, why is the patient not talking and stuff like that? She will write notes to you to talk to you, but she will not talk. Okay, so lack of speech, mutism is a negative symptom because you're lacking something. Anhedonia, lack of pleasure, lack. Okay, so negative is lack for schizophrenia. Positive, extra. Hallucinations, extra. Okay, delusions, extra. The neighbors are aliens, or the neighbors are trying to get me, or my friends are trying to get me. Again, disorganized speech and disorganized behavior, which is mostly agitated. Okay. So some recreational drugs that I just mentioned, hallucinogen, cannabis is marijuana, cannabis, and weed, all the same thing. But any of the drugs which are out there, we had a 15-year-old, like a young patient, come to the schizophrenia unit because he smoked marijuana for the first time. So some patients have predisposition. Predisposition means that they're already at risk based on their genetics to develop schizophrenia. And then you give them, they smoke marijuana for the first time, and it led to a full-blown psychotic episode. Okay, so these drugs can trigger schizophrenia. Since marijuana became legal in Canada, we have seen a huge increase in our schizophrenia patients. Okay. Okay, because they cause the imbalance of neurotransmitters, glutamate and dopamine, acute psychotic episode will happen. In rare cases, trigger a genetic. So triggering a genetic predisposition. Predisposition means this person was already at a very high risk genetically to develop schizophrenia, but didn't have the schizophrenia, now have smoked weed or did cocaine and has full-blown symptoms, psychotic symptoms of schizophrenia. What is the goal of therapeutic communication? Of course, building trust, self-awareness, reality testing, and self-confidence. Whenever you see a patient who is hallucinating, how would you know? Either they are talking to somebody in the vacant space, or they're looking at something, right? Or they're distracted when you're talking to you, or they're mumbling. Does that make sense? Because you have to think about, maybe they're talking to somebody else, or they are distracted because they are seeing things, or they are hearing something and they're responding back to it. Okay. Assess for hallucinations, of course, for safety, right? What are the voices telling you? Most therapeutic to ask what is being sensed. Again, I mentioned to you guys, how many types of hallucination? 5 types. What are the senses? 5 senses. You ask the patient, what do you sense? What do you see? What do you hear? What do you taste? What do you smell? What do you feel on your skin? Okay. All right. Assessment, how would you do it? First thing, social withdrawal, right? How many times I'm saying it does, schizophrenia patient, social withdrawal, very, very, very important. Okay. Concrete thinking. When I say concrete, I was thinking about it last time that when I was explaining to you, think about concrete. Concrete is like on a surface, right? Like when you have concrete on the road, it's on the surface. You can't go deep. So concrete is just, if you tell me, if you show a picture of like a wheel or a picture of a clock to a small kid, and you ask them, what is common in them? And they're going to say, it's a circle. Okay, so they just look at the things from the physical perspective. They're not going to say, oh, there are things, the clock has the hand and this has this. So concrete means surface level thinking, not understanding proverbs, muhavre, or grass is greener on the other side. They're going to go and check the grass on the other side. That is concrete, surface. Does that make sense for everyone? Abstract is deep thinking. Okay. Social inaptitude, meaning uncomfortable in social situations. You guys can write down or find out the meaning of inaptitude. That means the person is not comfortable in social situations. Okay. Whenever they go out, they are socially awkward. They are very uncomfortable because there are people around them, not because they have claustrophobia. Okay. Not because of that or agoraphobia. It's because of the schizophrenia that they are socially inaptitude. So we talked about the flat affect, right? Blunted or flat affect, negative. Hypochondriasis or depersonalization. We talked about these things too. Depersonalization kind of becomes one part of hallucinations when the person separates themselves from their own self. So the person I'm telling you, that the lady who thought that she was married to Jesus Christ, she used to like write, say her, I don't remember her name, what was, and I can't even tell you, but let's say her name was Mrs. Smith. She will write, Mrs. Smith and Jesus Christ has gone out for a date. So she is separating herself from Mrs. Smith. That means depersonalization. I am not the same person as Mrs. Smith, but she is Mrs. Smith. They just create 2 versions of themselves. in their mind, which means the depersonalization. Okay, so for example, I am Sarabjit and I start telling you, I think Sarabjit really likes to teach, but I don't know why. If I tell you that, that just means I am separating myself from my actual, like my actual me. I'm just making two persons out of one person. Okay, it's hard to understand until you see it. You guys will see it, but try to find out the word and you will understand. Suspicious. Why are they suspicious? Because they are threatened out of fear. Paranoid. If somebody is paranoid, you think they're going to be agitated and mad and hostile, right? They will be, because they think people are going to kill them. They're going to be like, oh my God, somebody's going to kill me. So these people are hostile. They are, they see that the world is like going to kill them. So they see the world as hostile. They think everybody's out there to kill them. Imagine the feeling. That's very uncomfortable, right? Just thinking that my friends are going to kill me. Okay. Poor reality testing, which means delusions, hallucinations. Neologism, meaning making new words, the words which don't exist. So for example, you have a word coin and chair, and they say chair. Like they make a new word. Neo means a new, logism means new word. It doesn't even have to have a meaning. They will just create a new word, which is known as neologism. Okay. Another one is clang association. Clang association will mean I will go up, and this like you know, it will rhyme. Clang associations rhyme. So they try to make it sound, it doesn't make any sense, but it will rhyme like a poem, like a song. Like if they say, now I can't think of something which is gonna rhyme, but just think of something which has a rhyming thing. But then there's word salad. Word salad is jumbled up words. Okay. Word salad, neologism, clang association, and loose associations are a part of schizophrenia. These are part of thought process. Okay. So of course, we talked about hallucinations and delusions, and they can have delusions of grandeur. Grandeur means they think they are very superior. They are married to Jesus Christ, or Jesus Christ comes to them. Persecutory, that somebody's going to kill them. Ideas of reference is the same, almost the same concept. Persecutory is like when they think that somebody's out there to kill me. Ideas of reference when they talk about other people. Okay. Assessment, I just mentioned loose associations, right? If you look at this one, the weather is sunny, the monkey has a long tail. Loosely associated. There's no relationship in between those two things, right? So that's what they do. Loose associations are formed. Formal thought disorders characterized by lack of connection. So loose meaning there is no connection between the two sentences that the person is telling you. Okay. I like to play games because the river is flowing down the mountain. So it doesn't make any sense. This is known as loose association. So if you say one sentence and then the other one, they don't connect, that is known as loose association. What is confabulation? Have you guys ever heard of the word confabulation? No, I will teach that in dementia, but confabulation means fabricating stories. Okay. Older people who have dementia, they will try to fill the gaps by fabricating stories. Okay. Of course, we talked about schizophrenia, short attention span, right? Regression. What is regression? Regression. Sandeep, what is regression?
When someone come to the previous comfortable stage.
Of what? Give me an example of regression, Sandeep.
Like ਕਿਸੇ ਨੂੰ copy ਕਰਨਾ.
No, that's wrong, Sandeep. Regression means going back into the previous developmental level. This is the third time I'm talking about regression. And if you're still telling me this wrong, that's not cool. Regression, I think Navjot has given the example of tenter temperams in the second class. This is the third time I'm mentioning about it.
Unconsciously suppression of
Sorry,
that.
Navjot, you're going to be louder. I can't hear you, dear.
Sorry. I said it's unconscious events to like not thinking.
It's a
of it.
defense mechanism. First of all, when I ask you what is regression, it's a defense mechanism. Harneet has gotten a question on defense mechanism, which is sublimation. What is sublimation? Mandeep, what is sublimation?
So that you're saying
Sorry, not Navjot. Mandeep, sublimation. So when I ask you guys question, even if you don't know, please unmute yourself and say, I don't know. Say it, Mandeep.
I don't know. I forgot it.
I don't know. Okay. Manjinder.
It's when we transfer our emotions to become socially acceptable.
Good. That's exactly what it is. Sublimation. Shiv Kumar Batalvi, sublimation. He became an alcoholic first because he was in love, and then he started writing poetry to put his negative emotions or energy into something positive. Sublimation and compensation are two different things. How, Manjinder?
Compensation when we are not good in one part and we are trying to compensate in like.
Good. Good. I am so proud of you, Manjinder. And I think Navjot was like, her face was telling me she knew about it too. Regression, sublimation, compensation, projection, all are defense mechanisms. And I have spent so much time on it. You guys are going to have to remember it. Okay. What is repression, Jagru?
Depression is like unconsciously, like searching the, like something happened, like we are unconsciously.
What are we doing unconsciously to that when something happened?
Like trying to forget it.
Exactly. Good. Very good, Jagru. I am so proud of you guys who remember the defense mechanism, because it's showing me that, yes, you guys have worked on it and remember it. Great. Very good. Okay, point 4, inability to meet basic survival needs. What are the basic survival needs? ADLs, activities of daily living. A person suffering from schizophrenia can have a poor hygiene because they have no interest in themselves. Sometimes their behavior is so bizarre that they will wear all the colorful clothes at one time. Okay, or they don't dress appropriate to the weather. Unable to feed themselves, they can't eat themselves, poor personal hygiene, or inappropriate dress. I just said all those things and then I realized they're written here too. Okay. All right. Again, positive symptoms, negative symptoms, and cognitive symptoms. Okay. Positive, extra, excess. Okay. So you can see psychotic, out of touch with reality, delusions, hallucinations. Again, disorganized speech is here. Lack of speech will be here. Okay. Disorganized behavior, that can be catatonic behavior, movement, posture, and response. And I'll tell you, anyone knows what is catatonic behavior? Probably not. Eh? Catatonic behavior is when a patient stands or sits or attains an uncomfortable position for a longer period of time. I have pictures of that, and if you have printed the slides, you will see them. Again, negative symptoms, lack of energy, loss of interest, anhedonia, alogia. What is alogia? A means absence. Logia means what?
Energy.
No.
Speech.
That's right here.
Words.
Who said speech?
Me. You just said.
That's right, Jackie. That's right. Yeah. Alogia is lack of speech. Okay. Evolution is lack of motivation. Anhedonia is lack of pleasure. Okay. Loss of interest would be apathy. I think lack of energy would be apathy. Can someone check that for me? Okay. Logia is speech. Okay. Neologism. Neo means new, logism means new words, new speech. Okay. Alogia means absence of speech, lack of speech.
Loss of interest is apathy.
Loss of
It's
yeah, okay. So
energy, I
loss of
think.
sorry. Sorry, Sandeep.
Uh, okay, that's the energy. I was saying energy, yeah, but that's the lack of energy.
Yeah, energia would be Anergia. But
Yes.
any word that has a in front of it is usually absence.
Okay.
These three terms are including apathy. So right in front of lack of loss of interest, apathy. All these four words you should know. Next time I ask you what is anhedonia, you guys should know it. Okay. Cognitive symptoms affects memory, learning, and understanding. That's why their focus is less. They can't study. I have seen schizophrenic patients who were doing PhD, and because of schizophrenia, they can't study anymore because their memory, concentration, and focus and understanding is getting affected. These are subtle, difficult to notice, but if somebody is in school, you can notice these things, right? Decreased attention span and concentration, disorganized thinking, disorganized thinking is here, poor problem solving and poor decision making. Okay. Example of poor decision making will be they will put clothes on which are like in 40 degrees, they are just wearing summer dress outside. That will be poor decision making. People do that, but that's because of some other reasons, not because of that. Okay, there are different types and presenting symptoms. I know that slide has it too, but these are some types to kind of, it's good to know. Disorganized type of schizophrenia is inappropriate behavior such as silly laughing and regression. Again, word regression is coming again. Transient, what is the meaning of transient? Transient hallucinations. Just tell me the meaning of word transient. Short time, transient, it's going to go away. Okay. Disorganized behavior and speech. Catatonic is sudden onset. Mutism, bizarre mannerisms are part of catatonia. Remains in stereotyped position with waxy flexibility. What is the meaning of waxy flexibility? Is when you have a patient and they, let me see if the next slide is. So this is catatonic behaviors, right? The patient may be staying in this uncomfortable position for very, very long time. And you will be surprised. You'll be like, how can someone just stay like that? Patients do. Schizophrenic patients do this, right? So for example, if somebody is standing like that and you moved their arm here, the arm will move. That is known as waxy flexibility. Anyone understands the meaning of waxy flexibility, like what it is? Like no matter how the patient is standing, but if you move their arm like that, it will be moved. If you move the other arm like that, it will be moved. But actually, they have the actual posture this, but if somebody goes to them and moves their arm down, it will come down. So it is catatonic, but they have the waxy flexibility. You know the word wax, like how the wax, candle wax, flexible. Like you can mold the candle wax when it's hot into any position. That is the meaning of waxy flexibility. Okay. They can become very aggressive and explosive at times. Next is paranoid, late onset in life, characterized by suspicion. As long as you know it at the back of your mind, it's good. Nobody's gonna ask you, like, tell me what type of schizophrenia this is, because most of the time schizophrenia symptoms overlap. But just knowing them that, okay, this is a type 2, paranoid schizophrenia is a type, undifferentiated is a type, disorganized is a type. Disorganized is when the patient's behavior is affected, like behavior, disorganized behavior and speech is happening. But that can happen in any form of schizophrenia. These types are divided on the main characteristics that the patient is presenting to with the doctor. Okay. So if the patient is coming with paranoid delusions, then that patient has paranoid schizophrenia. Undifferentiated, again, most of the schizophrenia becomes undifferentiated because symptoms of more than one type, right? Residual no longer exhibits overt psychotic symptoms. And what is the meaning of overt psychotic symptoms? No hallucinations and delusions are there anymore in residual, but they still have difficulty with social relationships. Okay. So this is example. Now, most important part is nursing care. What do we do? What am I supposed to do? So you always make brief, frequent contacts. Frequent because you're trying to establish trust and acceptance of the patient. Don't ever judge the patient. Again, all the characteristics of therapeutic communication will be applicable in schizophrenia. Okay. Gaining the client's trust gradually. Now, what is the meaning of gradually? Slowly. Build up, right? The patient does not trust anybody. Accept the client unconditionally. Okay? No conditions that, oh, if you will do this only, then I will do this or that. Unconditionally. There is no condition. You can come, you can sit with me. Assessing the client's readiness for longer contacts. Okay? The patient may not want to spend too much time with you. So that's why brief, frequent. If you have an 8-hour shift, you go to the patient every hour for 10 minutes. Okay? But once the patient has become comfortable with you, you can spend an hour or 2 hours with the patient. Okay? Being close by the patient during group activities, because of course, not in the initial phase, when they start going to the group activities, slow introduction to everything. Praising progress towards increased interaction with others, because what is the one of the most important nursing diagnoses of this patient? Disturbed thought process is one, which is hallucinations and delusions, and you guys have learned how to deal with them. What is the second most important diagnosis, nursing diagnosis of this patient? Impaired social interaction. Okay. What would be the third one? Self-care deficit. Are you guys understanding the importance of nursing diagnosis? It's very important to know what are the nursing diagnoses of a schizophrenia patient. Okay? Disturbed thought process because they have hallucinations and delusions. Second one, they lack trust, build rapport, all those things. So what would you do in the second one? What is the second one I just told you guys? Impaired social interaction. Third one, it could be self-care deficit. Okay? Assessing the client's readiness to engage with others and don't force the patient into a group. Okay? Schizophrenia patients especially, don't force them. Maintain the patient's safety, protect from altered thought process, because that is my first diagnosis. Decrease the stimuli, remove from areas of tension, no stresses, validate reality. Why are we saying validate reality? Because of delusions and hallucinations. You just want to validate the reality. You don't want to go too much into the detail of the delusions. But if the patient is having hallucinations, you do have to acknowledge the fear behind it, right? The patient may say, I see dead people walking around. Instead of thinking, what kind of idea is that? Do you have schizophrenia? That's why you see them. No, it's scary. It's freaking, like if I see somebody dead walking right now, I will just be so scared too. Okay. And imagine when you're talking to the patient and the patient seems distracted. Think about it. Maybe they are hearing voices. They can't even hear me. Sometimes you will see patients with big headphones, loud music walking around because they're having auditory hallucinations and they're trying to prevent those voices from getting to them. Okay. Recognize that the client is experiencing hallucinations. Be alert to hallucinations that command client not to harm themselves. Okay. Protect from erratic and inappropriate behavior, which will be catatonia too. Or sometimes these patients go and disrobe themselves in the public, take off their clothes in the public. And so communicate in calm, authoritative tone, address client by name, observe client for early signs of escalating behavior, or they can be very aggressive too, right? These patients who are paranoid can be suspicious of one of the other patients on the unit. What is your goal now? You have to protect that patient and them from themselves to hurting themselves. Administer antipsychotic medications. What are the antipsychotic medications? Antipsychotic medications. Mandeep. Hold on, Navjot. No. Mandeep.
Benzodiazepines, SSRIs, SNRIs.
Okay. Sandeep.
Benzodiazepine.
Okay. Who is telling you guys that benzodiazepine is an antipsychotic? Who told you that? Did I ever mention that? I must be so stupid if I mention that ever.
No, it's anti-anxiety.
Anxiolytics.
Yeah.
Benzodiazepines are anxiolytics. Okay. And SSRIs and SNRIs are what?
Antidepressants.
Antidepressants. We have not studied antipsychotics yet. Haldol is the only one that we studied. And I mentioned about Haldol being the typical antipsychotic, classic side effects, lot of dangers for the adult, older population. Orthostatic hypotension can happen. They can have EPS, extrapyramidal symptom. They can have tardive dyskinesia and all that stuff. Sorry, Navjot.
I said risk of fall will increase.
Risk of falling will increase with typical antipsychotics for older population. Yes, that's correct. But antipsychotics are classic and, like the classic old ones and the new ones. We'll talk about first generation and second generation. I'm going to cover them today. But benzodiazepines are not antipsychotics. They are anxiolytics. Okay. So nursing plan, we are still continuing with the schizophrenic patient. Meet physical needs, of course, physical needs of severely regressed clients, people who have gone into the earlier stages and need more care, right? When they will think, I can't take care of myself. Poor basic hygiene, poor nutritional habits, maybe non-verbal initially. Do not force into groups. It's coming again and again. Do not force the patients into groups. Establish a therapeutic relationship, engage in individual therapy. Institute measures to promote trust. Again, to promote trust, be consistent. If the staff is going on vacation, mental health patients need to know, okay? Because now you're changing things in the schedule. I have never seen this nurse. Who is this nurse? I want my nurse back. Where is my nurse? And you're going to have an episode, angry episode, violent episode of a client, right? Avoid direct questions, accept client's indifference. Indifference meaning if you smiled at the patient and the patient did not smile back, what is that sign? Flat affect. What is that, positive or negative?
Negative.
It should be coming from everyone. Why don't you guys speak up? Everybody should be like, yeah, negative, right? It's a lack of like expression. They are not expressing themselves. Hostility or sarcasm. Discuss all staff changes, as I just mentioned. Sorry. Nursing plan. Encourage clients' affect by verbalizing what you observe. What is affect?
Feelings.
Affect.
Expressions.
Expressions.
Facial
How
expressions.
you appear. I ask you, how is your mood? That is mood. Affect is flat. Like I don't have any expression. And I think I told you guys the story of my accident with no effect on my face. Okay. So you verbalize what you observe because affect can only be observed. Patient can't tell you what's my affect. Flat affect, you can tell the patient how you, so you can always tell the patient what you see, what you feel, what you smell, what you taste. Because these are objective findings. These are not subjective. If I can smell the urine, strong smell, that is an objective finding. Okay. If I can smell the patient stinky, or the patient has not taken a bath, I can tell the patient it smells this way, because you're not judging that, oh my God, it's so stinky or it's so bad. You can tell, I smell this. Objective, right? You always share your observation. Tolerate silences. The patient may talk, not talk, mute, right? Accept regression as normal part of treatment. Whenever there is a new stressor, regression can happen, right? And what is regression? Going back to the previous stage of development. If somebody is 15 years old, they're going to start behaving like a 9-year-old. If somebody is 20 years old, they're going to start behaving like maybe 10-year-old. So they are going back into the previous stage of development where they needed more love, care, and affection. With delusional regressions, respond to associated feeling, not to the delusion. If the patient says, I have no heart, that your answer should be, you must feel empty, because what are you going behind? The feeling. When the patient say, I have no heart, what does that mean? That means the patient thinks they are empty, right? Or if the patient tells you, I feel like I am in the ocean, you can tell the patient, you must feel lonely, right? Because if you are alone in the ocean, how would you feel? You'll feel lonely. You're like all alone in a big ocean. Help pinpoint sources of regression, anxiety about discharge. Sometimes the patient, when they are coming close to the discharge, they regress too, because they don't want to go. They were dependent on you. They liked the environment where they were feeling safe, but our goal, we can't keep the patients in hospitals forever. So we want the patients to be independent enough to bring them to normal level of functioning. Okay. Engage in family therapy. Engage in socialization. Again, socialization slowly, gradually, based on the patient's ability. Check if the patient is comfortable to socialize. Accept nonverbal behavior. Mutism, I'm mentioning this again and again. Impaired social interaction is a big part of schizophrenia, along with delusions and hallucinations. So accept the mutism, because they can't communicate with you. They don't know how to communicate. If patient cannot tolerate group, do not force or embarrass the patient. Act as a social role model for the patient. Provide simple activities or tasks to promote positive self-esteem and success. Finger painting. So these are good points. Finger paintings and clay are good choices for regressed catatonic clients. Catatonic, which are in altered, they go back and they are again like this. So finger painting can be encouraged for them whenever they decide to come out of that catatonic stage. Encourage attendance at occupational, vocational, and art therapy sessions. These are very important for them. Avoid competitive situations with paranoid patients. Why? Because they are already so paranoid about everybody. If you put them in a competitive situation, they're going to hurt somebody. So solitary activities are better for paranoid patients. Question. Can someone read this for me, please?
The nurse is caring for client with schizophrenia who has been experiencing visual hallucinations. The client says in a trembling voice, "There's a bad man standing over there in the corner of my room." What is the best response by the nurse?
Okay. Thank you, Manjinder.
Mhm.
Okay. Sandeep.
Number 1.
Okay. Mandeep. Mandeep, you need more time?
Yes, please.
Navjot.
Number 1.
Manjinder.
1.
Jagrup.
Number 1.
Everyone was saying number 1. What about number 3? Mandeep, sorry, Mandeep, what's your answer?
Same number 1.
Number 1, okay. What about 3? What does it do?
Distracting the patient.
No, it's not even acknowledging. I don't care what's happening to you. Let's go to the boardroom and play checkers. Okay. Hallucinations need to be acknowledged, right? The patient is saying it in a trembling voice. They must be very scared, right? You are telling the patient, I know you are frightened. That's how you sound like, but I am telling you the reality. Hallucinations, you can tell the patient, but I do not see a man in your room, because you're telling them the reality. That is how we talk to patients with visual hallucinations. I know you must be so, it must be so scary for you to see walking dead people around, but I do not see them. And you're telling them the truth. There's no lie about it. Okay. I will make the bad man go away, of course, false reassurance. Your illness is making you hallucinate. You do not talk to mental health patients like that. So let's go into the day room and play checkers. Although an okay option, but you're not acknowledging the patient's feeling. This can be after this. Okay. Firstly, you have to acknowledge the feeling behind the hallucination and delusion. Everyone clear about that? Feelings are like frightening, scared, feeling very overwhelmed. All those things are feelings. So acknowledge the feeling first. Okay, number 2. I'm not sure if you guys will be able to.
A client with schizophrenia says to the nurse, "The world turns as the world turns on a ball beat. But all the world's a stagecoach and I took the bus home." The nurse recognizes this statement as an example of which of the following? Is it tangentiality?
Word salad.
Lose of association.
Lose associations.
So your group and Sandeep are saying loose associations. Okay, anyone for concrete thinking? Anyone? Yes or no? No. Okay. I have one for tangentiality. That was Mandeep.
Yes.
Tangentiality. Do you guys remember the tangents? Sorry, my drawing is bad. They're never going to come back to the topic.
It nets connect the
Okay, even if you connect them, but tangent means like the topic is here, but you're going away from it. Even if you connect them, tangents can be parallel or whatever, but I'm just saying. But they never come back. Tangent people are just going, they touch it once, but they don't talk about it. That's tangentiality. They're just going somewhere else. In this one, word salad, it can't be, because word salad is like specific words that they are making a salad of the word. So one is spinach, one is chicken, other one is olive oil. It's a salad, but it's a salad of words. These are sentences, and the first sentence has no association with the second sentence. Like, I'm gonna go play, the river is flowing down, not because, like, I'm gonna go play outside, the river is flowing down. When the first one has no association with the second one. Like, there's no, if you try to establish a connection, you don't see, it's loosely associated, but it doesn't make any sense. So the nurse turns as the world turns as the world turns on a ball at the beach. But all the world stagecoach and I took the bus home. Like, what? It's not connected. It's not tangential, because he's not even talking about anything like that. Give me 1 second. Let me see if I have more. If I wrote something else. Okay. So disturbance in thought process is one of the positive symptoms. Of course, we talked about it. Disturbed thought process is extra. The nurse needs to be able to recognize and identify the various types of thought disturbances experienced by clients with schizophrenia. And these are some of those examples. So the patients experience loose associations, neologism, word salad. What is echolalia? What is echolalia?
Repetition of words.
Yeah,
Repetition of words.
repetitively.
When
saying
they
the word
repeat
with no
after
meaning.
you. When they repeat after you. Okay. I'm just gonna find the tangential thinking. I think I have some notes. I will send it to you guys, but I wanna read the definition to you guys. Okay. So tangentiality, I'm just reading from, actually, give me a second. So tangentiality, move from thought to thought that relate in some way, but never get to the point. That's why I was drawing the tangents like that, because they never get to the point in terms of tangential thinking.
Like
So
politicians, like politicians.
yeah, exactly. They're like that. They will actually relate in some way, but never get to the point, the question you have asked them. They have answered a question, but you never know, like, what was the answer? You can't pick it up. Okay. So I'm gonna try to find for you guys, and I will send it to you. Give me a second. I had it, but it was mental status examination, but then I was thinking you guys may not need it, but now I feel you do. So tangentiality, you never come to a point. Word salad, let me see an example of word salad for you guys. Oh, my. Okay. So if we read this unintelligible mix, so a jumble of extremely incoherent speech, or sometimes observed in schizophrenia. Let me see. They're not giving an example. Okay. So schizophrenics often speak or write some form of word salad. An extreme example of word salad is red changed dog well. In this example, there's no sense between the words at all. So it's just a mixed up, jumbled words that is known as word salad. But I will send this to you guys. I'm going to have to find it. Okay. Disturbance in logical form of thought is characteristic and one of the blank symptoms of schizophrenia. Positive or negative? So all these things that we just did, loose associations, neologism, word salad, tangentiality, what are these? Disturbance in logical form of thought, right? They're not able to present their thought logically. Is that positive or negative?
Positive.
Okay. Navjot, you're thinking it's negative?
Yeah.
Why? Isn't that extra? Isn't word salad extra?
Yeah.
Isn't loose associations extra? Like they're not able to associate, but they're extra, talking to you extra. Tangentiality, not coming to the point, extra. Isn't it? Shouldn't it be positive? It will be positive. Disturbed thought process is positive because disturbed thought process is also hallucinations and delusions along with all the things that we have studied, okay? The client will often have trouble blank and maintaining a train of thought. Trouble in what? The patient have trouble in what?
Association.
Concentration. Okay? Concentration, they can't focus. That's why their train of thought goes somewhere else. Thought disturbances are often accompanied by a blank level of functional impairment. So how much functional impairment is happening? High level. Okay? High level of functional impairment. And the client may also be agitated and behave aggressively because they can't function.
Is echolalia is a symptom?
Echolalia can also happen. That is part of disturbed logical form of thought. Echolalia is if you say something, they just keep repeating that. Okay. There's another term, perseverance. I'm going to send it to you guys all. I just need to find it out where I have put it. But perseveration is one of the terms when the patient, perseveration means it's actually a positive word, but still the patient keeps persistently talking about the same topic again and again and again. Like they will keep talking about the one thing. They will perseverate on it. Okay? Nursing care of a client who acts withdrawn. So people who act withdrawn are socially withdrawn, right? How do you take care of them? The first the problem with them is lack of trust and feeling of safety and security. That's why they are withdrawn. We have covered this all, but I'm just repeating it. Keep interactions brief because you're trying to gradually establish trust, especially the orientation phase. Structure environment means breakfast at this time, lunch at this time, and dinner at that time. Okay. Be consistent and reliable. Decrease physical contact, allow physical distance because the patient is insecure. Eye contact during breathing, patient may not make the contact, but you have to make the eye contact. Maintain attentiveness, accept client's behavior unconditionally. Hallucinations, we have talked about it so many times, excuse me. Maintain accepting attitude. Do not argue with the client about reality of hallucinations, okay? Comment on the feeling. I have mentioned this multiple times, and it's a very, very important point. Comment on the feelings, how the patient is feeling, and the tone of hallucination. That must be frightening to you, but I don't see it. Encourage diversional activities. I just mentioned the big headphones with the loud music or TV or something too, and distract them from the hallucination. Encourage discussions of reality-based interest. What is the patient interested in? Do you like reading book? What kind of books do you read? Do you like watching movies? What kind of movies do you watch? Lack of attention to personal needs. We talked about hygiene. So if you think about, again, the same things, disturbed thought process, hallucinations, delusions, loose associations, clang associations, all that. Lack of trust is coming from impaired social interaction. And the third one is the patient's self-care deficit. Okay. Assess adequacy of course, you want to make sure your patient is completing the ADLs, bathing, like the patient is clean, maintaining the personal hygiene, coming for breakfast, drinking water, eating food, offer encouragement or assistance if necessary, decrease environmental stimuli at mealtime. How would you do that? How would you decrease the stimuli at mealtime? Mealtime is a social time. It's so busy. How would you do that? Think about it. What can you do? You are the nurse on the floor. You can make any changes you want to, but what would you do?
We can feed him or her in the room.
You can turn the TV off, the daycare room.
That should be off anytime. Like some of the basic things, TV should not be on in the dining room when the patients are eating. Okay, because the focus is food. We want them to enjoy the food, although we all watch TV when we are eating, but it's not a good habit. Decrease environmental stimuli. You can ask for early breakfast, early lunch, or early dinner. Because your patient is still paranoid and do not want to have social interaction at this time, because what do you have to do? Social interaction is slowly, gradual, when the patient starts feeling comfortable. Okay, so what do? We tell them that I want to have early lunch for my patient. Yes, Navjot, we can give them the food in the room, but at one point of time, you have to bring your patient out of their room, because at the end of the day, you're establishing a functional level, like a functional level for them. And if they keep eating in their room, they will become dependent on you to bring them the tray. And hospitals do not allow for mental health patients to be eating in the room until and unless there is a reason for that. Because everybody, imagine depressed patient, they're never going to come out for food, right? They're going to stay in the room. They're going to spend the whole time in the room because they don't want to come out. So we do that. Catatonic patients, because they are in like weird positions, you want to make sure the positioning and skincare is done in catatonic patients. Okay. All right. Suspicious patient, again, same. Mistrust and feelings of rejections. Keep appointments with the patient, clear, consistent communication, genuine and honest. Recognize that the patient could be testing you by saying, I don't need you, but you have to continue to show up saying, I am still interested in you. Okay, because the patient could be testing, is the nurse really interested? Or if I tell her go away, she's gonna go away. And the patients do that a lot. Okay, but we still keep going to the patient to check, it's time for lunch, let's go for lunch. You want to talk to me, I am here to talk to you, I'm interested in you, we can sit together and watch TV. You don't want to talk, we can just sit together, you know. One of the slides said become comfortable with silence. Okay. Delusions, sorry Navjot, you're saying something?
Nothing, sorry.
Okay, that's okay. Delusions, again, allow client to verbalize the delusion in a limited way initially. The patient can tell you what they are deluded about, but you don't do an elaborate conversation on delusions. Do not argue with the client to try to convince that the delusions are not real. Point out feeling, again, feeling of the hallucination and feeling tone of the delusion. Provide activities to divert attention. Solitary activities best at first and then may progress to non-competitive games or activities. Do not reinforce delusions by validating them. Focus on potential real concerns of the client. These are the same things we have talked multiple times. Now, antipsychotics. Okay. First generation and second generation. Please start making notes or, you know, whatever you guys want to do. I'm thinking, how can I, give me a second. I want to enlarge my screen. Okay, I think this is better. Okay, so the first things first. First generation, second generation. Which ones are better? Some patients only first generation work for them. Some patients are still there that second generation work. Second generation are better, but if you think about clozapine, it may not be the best drug, right? Clozapine comes with a lot of stuff that I will be talking about tomorrow. It causes agranulocytosis. A lot of blood sampling is required. In Canada, they have a clozapine coordinator. If a patient goes on clozapine, we have a clozapine coordinator who follows up with the patient consistently. But in terms of first generation antipsychotics, there are only three: Haldol, loxapine, and chlorpromazine. Okay, so these are, if you want to remember it, HCl, hydrochloric acid, HCl, haloperidol, chlorpromazine, and loxapine are the three. You don't have to remember the trade name, to be honest. Like the NCLEX is going to give you both the names. So I focus mostly on generic names because most of them, I remember them by generic names, except as some of them, like Abilify is a long-acting injection too, so I remember that we used to give it to our patient. And Seroquel as a drug, we give it very often to the patients. Okay, but remember the generic names. So we're going to talk about typical first. Typical, older generation, first generation, conventional. The problem with typical is side effects. And we will, first of all, let's look at the action. What is the action? Blocks or inhibits, because what did we say? How is schizophrenia? What is one of the causes of schizophrenia?
Dopamine.
Increase in dopamine, right? Too many delusions, too many hallucinations means too much dopamine. Okay, so blocks or inhibits dopamine from being released in the brain, helps diminish positive symptoms. Does that make sense? These two lines, does that make sense to everybody?
Yes.
Mandeep, does that make sense? Why these two are connected?
Yes.
Okay, good. Manjinder,
Yes.
Sandeep, does that make sense?
Yes.
Okay, good. Okay, great. Sorry, Jigrup, I didn't ask you, but I thought I heard you saying yes. Okay, now let's go to the side effects of these. Very, very, very important. Tardive dyskinesia, EPS, and NMS. Tardive dyskinesia, extrapyramidal syndrome, and neuroleptic malignant syndrome. I will be covering tardive dyskinesia, like all of them tomorrow, because I'm gonna, hopefully we can have, I have 75 slides. I usually do 60 in 4 hours, but we'll see if we can cover the 74 slides, but that's okay. So tardive dyskinesia is like an involuntary movement of the face, tongue, or limbs that may be irreversible. Okay, you know, like the tomorrow's class, you guys will see the pictures. So the tongue is out or on the side, the face movement, it's involuntary, but it's not reversible. Okay, important point. Please highlight it or please write it down. TD, tardive dyskinesia, is irreversible. You cannot reverse it. Even if you stop the antipsychotic now, you can't reverse it. Imagine how dangerous it is that you gave somebody Haldol and now the patient's face have involuntary movements. You have stopped the drug, but you can't reverse it, right? Big deal, because you have changed someone's appearance. EPS is like Parkinson's symptoms. Extrapyramidal syndrome is like Parkinson's. Parkinson's has restlessness, dystonia, all those things can happen in extrapyramidal syndromes. Neuroleptic malignant, I'm going to cover tomorrow. And malignant syndrome means combination of symptoms, EPS, high fever, and autonomic disturbance. What is autonomic disturbance? Anyone knows what is autonomic disturbance?
Like involuntary, like blood pressure,
Blood pressure, heart
temperature,
rate,
respiration.
yeah, autonomic, right? Like they're not under your control.
Under control, yeah.
But I'm gonna define this way more. She hasn't done, like, I don't think she's done the best job in explaining these, but she's covered it in one slide, which is great. So combination of symptoms, one can recover 7 to 10 days after DC, means discontinuation of the medication, but it can be fatal if not treated in time. Neuroleptic malignant syndrome is very, very dangerous. Now, let's go to the second generation. Okay, first generation has so many problems. Now, what is second generation? Second generation is risperidone, clozapine, quetiapine, ziprasidone, and aripiprazole. So try to make some name out of it and put it on your wall. All these things are very, mental health drugs are very important. And sometimes a student calls me and says, oh, you know, they gave me something Ari, but I don't know what the drug was. I'm like, I taught you that. So that must be aripiprazole. Okay. So action is they act on both serotonin and dopamine in the brain now. So when you think serotonin, when the depression happens, what is decreased? Jagrup, what are the antidepressants?
Serotonin decrease in depression.
Serotonin decrease in depression because antidepressants are SSRIs, and SNRIs. Decrease in serotonin, we're trying to increase the serotonin because it's a good neurotransmitter. So negative symptoms, when you look at the negative symptoms of schizophrenia, what do you feel about? It's almost like depression: lack of speech, lack of apathy, evolution, elogia, anhedonia, all those are lack. That's equivalent to almost depression, right? So those are the negative symptoms. Second generation works on both positive and negative symptoms. Why? Because it works on serotonin and dopamine in the brain. Okay, does that make sense to everyone? I just see Navjot's head shaking. I don't see the group. Does that make sense?
Yes. Yes.
Yeah. Okay. Tell me now, and I will repeat it again. Manjinder, does that make sense? Good. Okay. Nobody's ever going to go into this much detail, but I'm telling you, these are the facts. These are the information that will help you in understanding the drugs more. Second generation, the S in second, S works on serotonin and dopamine. Take the S from second generation and then make it work. But remember the drugs: risperidone, clozapine, quetiapine, ziprasidone. If you think about it, like one is AC and PQ, like QR. I know there is no P, but if you think about Z, ziprasidone, and take it from P, PQR. You can do AC, PQR if you want to remember the drugs second generation, but you do need to remember all these 5 drugs. Okay? I'm going to ask all these 5 tomorrow if you remember them or not. Okay, so remember these 5, remember these 3, 8 drugs for antipsychotics. You have to remember the names. Okay. All right, side effects of both of them, the common side effects now. Anticholinergic effects. What are the anticholinergic effects? Urinary retention, constipation, dry mouth. We give our patients Ora gel when they are on antipsychotics. okay, because their mouth is so dry. Or we give them the tears, refreshed tears, because their eyes are so dry too. Photophobia, photosensitivity, and sedation and lethargy. Okay, so think about Haldol. We give it to a patient on chemical restraint. Does it cause sedation? Yes. Think about, you are disturbing the dopamine, and is it going to cause the sleepiness? Yes, it is. Increased dopamine, when you wake up, your dopamine is high. When you're in a good mood, you are in a party, dopamine is high. When you're home, your dopamine levels go down. You are tired, you want to go to sleep. So sedation and lethargy can happen. Okay. Now, the problem with second generation causes a lot of problem. There is a lower risk of tardive dyskinesia, extrapyramidal symptoms, and neuroleptic malignant syndrome, which is very common in the first one. There is no orthostatic hypotension. But the problem with the second generation is patient gains a lot of weight. It affects their self-esteem. It leads to low self-esteem. Okay. Weight gain, high cholesterol, high triglyceride levels. With triglycerides, cholesterol, and increase in blood sugar, what are the patients at risk for? Diabetes. Okay, be careful with diabetic patients. Many of our patients are on metformin when they're on second generation antipsychotics, because metformin helps the blood sugar levels and with the weight of the patients. Many of the patients that I have given antipsychotics to, the second generation one. So now if weight is changing, cholesterol level is changing, triglyceride and blood sugars are changing, that means many of the GI problems are happening with second generation. The patient's compliance is usually poor with the second generation because they don't want to gain too much weight. And like I'm telling you, I wish you guys can just use my brain here. I have seen my patient coming in at 100 pounds, a handsome young guy, and I see them 3 months later and they are 200 pounds, a big guy now. Okay. So that happens. All right. Contraindications, hypersensitivity, of course. Comatose client, you can't give it. Depressed, you can't give it. Bone marrow depression, clozapine, you can't give it. Blood dyscrasias, you can't give it. Again, clozapine, right? It affects the blood levels. Parkinson's disease, why do you think you can't give in Parkinson's disease? EPS, extrapyramidal symptoms, are similar to Parkinson's. If you give somebody the drug, the first generation, and they have Parkinson's, now you don't know if it's the Parkinson's or the side effect of antipsychotic. Liver problems, coronary artery disease, and hyper or hypotension. Nursing consideration, you always have to educate. Mental health drugs work slowly, except benzos, because benzos are for anxiety, fast acting anxiolytics, work really, really fast. I don't remember how many times I've snapped my finger since I said benzos. Benzos are fast, very fast. Okay? They are given for seizures under their tongue. Lorazepam. Lorazepam is also given for anxiety. Lorazepam, midazolam is given for anxiety before a procedure. Tell client about adverse reactions and emphasize that adherence is very important. Patient needs to comply with the medication. First generation antipsychotics teach signs and symptoms of TD, tardive dyskinesia, extrapyramidal, and neuroleptic malignant syndrome. Neuroleptic malignant syndrome is a medical emergency. The patient can die. Okay, we'll cover that tomorrow. Advise the client to get up slowly. Why? Why are you advising the patient to get up slowly?
Hypotension.
Orthostatic hypotension. Okay. Second generation, check the labs. What labs should you check? Blood glucose, triglycerides, cholesterol. Also, weigh the patient. You have to weigh the patient. And we weigh this patient. Advise the patient, tell them to go for exercise, tell them to take a low calorie diet. Okay, and monitor their weight. Is everyone good with this? Can you guys be able to remember? Do you understand it? I am not asking about remembering. Do you guys understand? Okay. How many of you already knew about the difference between the first and second generation?
No.
She looks like no. Navjot is like no too. Sandeep, Mandeep, Manjinder.
I
Some
knew
of
a
them
little
I
bit.
Manjinder, you knew a little bit? Okay, good. So tomorrow, please, tonight, before you go to bed, it should be like imprinted in your brain. You do your cramming, you do whatever. I'm going to ask questions from it tomorrow. Okay. Next is bipolar disorder. What is the meaning of bipolar disorder?
Mania and depression.
Mania and depression.
Depression and mania. That's right. So you can see here depression to mania with periods of normalcy. There is normal too. Mania, depression, like there's normal stage too. So manic phase is what? Euphoric, high mood, irritable, hyper, like everything is high. They're very high manic patients. Sign and symptoms are restless. They can't sit still. Flight of ideas. They have too many ideas. Okay. Grandiosity, hyper mood, poor judgment. Can you say when we are really happy, we make poor decisions, right? We do. Like people who are very happy, drunk, they're, oh, I'm gonna drive today. I know how to drive. Poor judgment, right? Manipulative behavior, because manic patients just want to get their way around. So they are manipulative too. We talked about personality disorders. The second cluster is manipulative, right? Wired people, antisocial people are manipulative, histrionic. The whole cluster is freaking manipulative. Decreased sleep, when the patient is manic, they don't sleep. So sleep deprivation is one of the problems too with manic patients. They don't eat, they don't sleep. They have delusions and hallucinations too. So they come in a stage of delusion, hallucinations. Who was this patient when I sent you the videos?
Mania patient also.
John was manic. You guys
Was
remember
doing
John?
some research.
Yeah.
Sorry, Navjot, I didn't hear you.
The the patient was doing some research. She was not
Yeah,
talking.
exactly. The
Cancer.
doctor asked him, are you
Was
sleeping?
so
I
quick.
don't need any sleep. Sorry, Navjot,
Yeah.
keep going.
Yeah.
Sorry,
Yeah, he was so quick, not even listening to that therapist.
right? Flight of ideas. Did he have flight of ideas? Was he
Yes.
restless? So tonight you guys are going to watch the video again and have this slide right in front of you. Okay. He was grandiose. He was thinking who was meeting him? The God. He's talking to the God. Hyper mood. Oh, my mood is really good. Poor judgment, right? Impulsivity, elevated activity, very active. Like I don't need no sleep. Okay. So for clients with mania, the nurse should offer energy and protein dense foods because they don't eat. So you can see hamburgers, sandwiches, because you want to give them high calorie, high protein food. I know, Navjot, I'm like also you like looking at finger foods like toddlers. They're so busy. They don't want to sit and eat. Manic patients are same. They don't want to sit and eat, so they lack in nutrition. Depressive phase is the same, periods of low mood, sad, low energy, sleep disturbances. But patients mostly come to you in manic phase because remember John said that my friend called me manic mechanic. Remember that? He was manic. Go back and watch the video. Navjot is going to say something. I don't know. Navjot, were you going to say something? You're laughing.
I know he was a mechanic and he said that.
Sorry?
He was a mechanic. That's why I remember that phase.
Yeah, manic mechanic, right? So imagine how important those videos are for you. Does that click with you now that you guys remember him? Didn't want the doctor to talk. Respectful to doctor means impulsivity. Can't control the impulses, you know? Treatment nursing consideration, the first thing is, of course, safe environment because they can hurt themselves or others too. Set limits on manipulative behavior. How many times the doctor had to tell him, okay, let's talk about this. And he's like, no, you talk about my numbers. No, let's talk about this. So that you have to set the limits on it, okay? Provide finger foods and fluids, rechannel energy for physical activity, decrease the stimuli for them. No TV, Nothing, not group activities. These patients should not go to the groups, because what are they going to do? They're going to take over. If you send John to a group activity, what's going to happen? Is he going to let anybody else talk? Right? So not like that. Keep away from other clients if they are bothersome. Manic patients and depressed patients, sometimes you have a group and you have a manic patient, and then there's a depressed patient, and you brought the depressed patient with a lot of efforts that, okay, you know what, you should come to the group, do this and that, and then you found a manic patient now. And the manic patient is talking and the depressed patient is getting even more depressed. So they don't work well in the groups. Okay. Pharmacology, lithium, mood stabilizer. Okay. Anticonvulsants, antidepressants, antipsychotics, and anti-anxiety. All the drugs work in the mood disorder, bipolar disorder, okay, for different reasons. Okay, now I have a little bit of detail, except her slide. Elation or grandiosity can be a defense against underlying depression or feelings of low self-esteem. Mostly people who show themselves to be very rich or big people have an underlying low self-esteem. Okay, so that is just in general too. When you see people flaunting themselves a lot or showing off a lot, it's coming from a place of insecurity. Okay, it's coming from a place of low self-esteem. That's why social media is not like, that's why people say don't go by the social media, because social media is not the best indicator of how people are actually feeling. We are just looking at the picture objectively. We are not thinking that what the feelings of the person behind this picture is. The person is posting the picture to get some reassurance, likes, that I am still a likable person, or I am pretty low self-esteem. Okay, so that's, sometimes those are the feelings. Not everyone has the same thing, but I'm saying some of the people, they do have these things. Predisposing factors, hereditary, genetics, biochemical. Problems, of course, easily stimulated by surroundings, hyperactive, anxious, unable to meet physical needs. They will not sleep, they will not eat, they will not perform personal hygiene, and all those things. Aggressive and hostile due to poor. Can we agree all these things happened with John? Denial, he didn't want to accept something was wrong with him. Okay, he was testing, manipulative, demanding, disruptive. Oh, bring me the food. Who's the in charge here? I want to meet the in charge. You are a shit boss. Do you guys remember all that? You guys have to watch the video to remember all that part. But watch the video, go over bipolar disorder. It will make so much more sense. Okay. They also have superficial social relationships. Okay, assessment, disoriented, incoherent, delusions of grandeur, cheerful, euphoria, flight of ideas, easily distractible, inappropriate dress, excessive makeup and jewelry, lack inhibitions. Lack inhibitions means that they don't want to control themselves. Use sarcastic, profane, and abusive language. He did. So all these things you guys can think about. The other problem with the manic patients is sexually hypersexual. They're very hypersexual, and they ended up getting into different types of social sexual relationships with people, and sometimes are at a very high risk of getting STIs. Okay. Weight loss can happen because they're not eating. Insomnia happens, regressed behavior. They can't stop moving when they're eating, their appetite is decreased. Nursing plan, of course, what can we do? Simplify the environment, remove the stimuli, assign to a single room because you don't want to disturb the person next. Keep the noise level low. It's like almost like having a dark room with less stimuli, like for a seizure patient, pretty much. Okay. Away from the nursing station, of course. Why? Because they're so hyper. They're going to keep, I don't know if you guys have experience. Have you guys worked in Canadian system as a night shift? Nursing station is so busy at night too. Like we are so busy at the nursing station because the nurses are coming, we are talking, we are doing things, we're taking breaks and stuff. Limit people because more people will stimulate them more. So will you take them into group activities? No. Right? They like an audience. We don't want to remove to quiet areas. Distract and redirect energy. We take them. They don't have a longer attention span. So you do the activities which need less attention span, but needs a lot of energy, like chores, walks. Choose physical activities using like dancing in acute mania because they have so much energy. But when the energy subsides, ask them something to write which keeps them really busy. Okay, you can ask them for political suggestions and plans, but they can't write in acute manic condition, right? So provide external controls. Assign one staff person to provide controls. Do not encourage client when telling jokes or performing. Avoid laughing. So the physician did not laugh at his jokes at all, right? At John's joke, John was trying to crack jokes, but the physician did not laugh. They call me, oh, I call him beardy, ha, 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 ha. And then he said, oh, he calls me manic mechanic, ha, ha, ha. So she did not laugh at him at all. Okay, because she's not encouraging him. When you're laughing at my joke, that means you are encouraging me that I can continue. Accompany client to room when hyperactivity is escalating. Guard vigilantly against suicide as elation. So now this is a BPAD, right? Manic and depressive phase together. When the manic phase has gone, now what is the patient at risk for? Depression, suicide, what have I done? Right? So these patients are also at risk. Institute measures to deal with manipulativeness, set limits, very important. Set firm, consistent times for meetings, client often late and unaware of time. Refuse unreasonable demands. Manic patients will ask the nurse, can you go for a date with me? That's an unreasonable demand from any of your patients. Explain restrictions on behavior and reasons so the client does not feel rejected. Communicate using a firm, unambivalent, consistent approach. What is unambivalent? Ambivalent means you are saying yes and you're saying no at the same time. Okay. Ambivalence is feeling. You guys can search the word ambivalence. Ambivalence is mixed emotions. Ambivalent means consistent, one approach. If the answer is yes, it's yes from all this stuff, because ambivalence confuses the patients. Okay. Use staff consistency in enforcing rules. Remain non-judgmental. Never threaten or make comparisons to others. Avoid long, complicated discussions, because what do they want to do? They want to talk a lot to you, right? They'll take all the time. Use short sentences with specific straightforward responses. Avoid giving advice even when solicited. Solicited means even when asked. You don't give advice to any patient anyway, right? You don't give advice. So these patients, what do you think I should do? Manic patients can ask from you. You don't give advice. Meet the physical needs and nutritional needs, sleep needs, rest, right? Encourage fluids, offer water every hour, because the client will not take the time to drink water. High calories. So this can be a question in exams. What kind of foods? So the slide has hamburger, sandwiches, because something that is easy to carry and is high protein and is high calorie. Okay, remember things like foods that are easy to carry, like patient can eat while walking, because this patient will not sit down when eating. So hamburger has a protein patty in it and it's high calorie because of the bun, right? Does it make sense? You can get a question like that. Serve meals on tray in client's room when too stimulated. What is the reason for that? You guys were asking me to give meals to a patient in the room and I said no, but I am saying here, serve it in the patient's room. Why?
It will,
Harm others.
Not harming others, but
it will
people,
distract.
he will disturb
Stimuli.
everybody. Disruptive, too stimulated. They like an audience. They like people around them. So dining room is a social interaction. We have had a manic patient who used to just eat really fast and come out in the dining room, disturb everybody in the dining room and will not let other people eat. Encourage rest. Of course, you want to encourage, because they don't feel the need to sleep. So sedate PRN. Sometimes the patient is up until 2 o'clock at night. So you give the patient sleep medication at that time when they're manic. Encourage a short nap because you want them to rest. Supervise bathing routines because they will take too much time or sometimes too distracted to clean and just keep playing with the water. But they spent 2 hours in the bathroom and did nothing but just played with the water. So you have to keep an eye on these patients. Administer medications again, mood stabilizing medications. Lithium, of course, is a mood stabilizer, whereas valproic acid and carbamazepine are antipsychotics, but are used anticonvulsants, because you guys must have heard about valproic acid as an anti-seizure medication, carbamazepine as an anti-seizure medication, but it is also used in the BPAD. Okay, these are the drugs which are off-label. Okay, help decrease denial and increase clients' awareness of feelings. Encourage expression of real feelings through reflection. Again, reflection is you let the patient reflect on the situation. Function as a role model for client by communicating feelings openly. Always role model for the patient. We are always role models, right? Help client recognize demanding behavior. Encourage client to recognize needs of others, because they will take so much time from you that they will let the other depressed patient meet no needs at all. Sorry. Oh. Have client verbalize needs directly, wishes for attention. So the patient should say, I need attention right now. Please talk to me. The patient should say that. Let's see. I think this is, so I'm not going to do this one, but this is the one I want to do today, but I will cover it tomorrow too. Lithium carbonate, one of the most important drugs. All of you have heard the video of Harvanit, right? So I'm going to mention some of the very important things today that you guys have to remember. So known for its side effects and narrow therapeutic range. Which other drug has a narrow therapeutic range that Alvin has taught you?
Digoxin.
Digoxin, dangerous. What is the meaning of narrow therapeutic range?
Very less in the mind.
Like they are therapeutic of one very less, like it's very small. You can't risk this drug. There's a very small concentration of this drug in the blood, which is safe. That is known as narrow therapeutic range. Safety. Therapeutic range means safety. It's only safe if it's at 1.2. So 0.6 to 1.2 milliequivalent per liter. And digoxin is, I think, up to 2.8 to 2. Yeah. Right? 0.5. So they are close. Whatever digoxin is, make sure that you guys write them together because these two are very close. That is in nanogram per deciliter, I think, but the same. This is 0.6 to 1.2. So uses lithium is a long-term treatment. I want to tell you one very interesting story about lithium, but let me cover the important points. Helps regulate the mood swings, depression, and mania both. So long-term, L for long, L for lithium. One of my patients was stable on lithium for 35 years. Okay. She came to the hospital because now she's again has mania, right? She's in manic stage. And the doctor does, lithium affects the kidneys. Okay. Lithium gets excreted from the kidney unchanged. Lithium is an ion, Li+1. Remember periodic table? It was below hydrogen, Li+1. Lithium gets eliminated through the kidney unchanged in the ionic form. So what is it toxic to? It's toxic to the kidney. So somebody who's taking lithium for 35 years, what are they at risk for? Chronic renal failure. Okay. My patient developed chronic renal failure. She was only stable on lithium, but now the doctor can't give her lithium anymore because she has chronic renal failure. Okay, so they had to change the drug. So lithium is toxic to kidneys. Okay, but the treatment is required for long. That's why therapeutic range is very important. So adverse reactions: nausea, drowsiness, fatigue, thirst, dry mouth, weight gain. Okay, you guys are gonna have to remember these. I have multiple slides tomorrow on this topic, so you guys can remember this, and then like we'll cover those two. So toxicity level, there's mild, moderate, and severe. Adult, older population, older adults are even hypersensitive to lithium. Why? What happens with age to kidneys?
GFR decreases.
GFR decreases, right? Creat clearance decreases. So that means the kidneys are not able to function 100%. So elderly population, the lithium toxicity will happen even faster at a smaller range. Make sense? If the question says older adult, they are at a higher risk of lithium toxicity. Okay. So what are the signs? So, okay, Harneet mentioned one thing, side effects expected versus toxicity, right? Adverse reactions, yeah, like it's a concern, but sometimes the things are unexpected that can happen, but are dangerous. So in this case, it's confusion, blurred vision, diarrhea, tinnitus. Think about all these things. Blurred vision, the vision is blurred, very dangerous with lithium. Confusion, the patient is confused. That's why we go back to, oh my God, the patient is confused. Like, what's going on? Is there something wrong? Confusion, diarrhea, tinnitus. What is tinnitus? Ringing in the ears.
Ringing
What
in.
else causes tinnitus? What other drug causes tinnitus? One of the other drug side effects is tinnitus. You guys find that out for me tomorrow, okay? Slurred speech, coma, convulsions, excessive urination, which is polyuria, polydipsia, tremors, and ataxia. Okay, so central nervous system is getting affected so much that the patient has convulsions, polyuria, polydipsia, ataxia, coma, confusion. So if when you do, so tomorrow when you see the topics, divide the toxicity, CNS toxicity, GI toxicity. When you do CNS, you will take confusion, even blurred vision will go under CNS toxicity. Okay, tinnitus will go under CNS toxicity, slurred speech will go under CNS toxicity, coma, convulsions, excessive urination, thirst, tremors, everything is CNS toxicity. Look at it. Is there anything that you guys feel should be something else? Right? CNS toxicity. So these are the levels. 1.5 to 2 is mild because 1.2 is the range. 1.5 to 2 is mild. 2 to 3 moderate. More than 3 very dangerous. How does toxicity happen? Okay, now dehydration. What happens in dehydration? What happens to the body? Which electrolyte is high in the body in dehydration?
Sodium.
Calcium.
Sodium.
Sodium. Okay, so the patient is
Hypo-
dehydrated.
Sorry.
Not high, we'll say,
Hypo-
think about it in this way, that the kidney is trying to,
hyponatremia cause lithium toxicity, right?
yes, I'm going to tell you why. So what happens, sodium and lithium are Na+1 and lithium is Li+1. When there is dehydration, the kidney is trying to save who? Sodium, right? Instead of saving sodium, what is the kidney saving now? Lithium. Make sense? Okay. Kidney has a tendency to save sodium when we are dehydrated, because if the sodium is in the body, it will retain the water. But now you're losing water, sodium is going to be high, but instead of being sodium high, the kidney has also stored lithium. The kidney is not letting the lithium go out. Hyponatremia, again, same situation. Okay. If the body has low sodium, what is happening? Okay, let's go to number 3, old age and kidney failure. This is clear to everybody? That why
Yes.
is this toxicity happening? Tell me if you guys understand hyponatremia. If there is low sodium in the body, what is more? Where
Water.
lithium can connect at more places and cause toxicity. Hyponatremia, the kidney is going to try to prevent the sodium from losing. Who is the defense mechanism for any of the electrolytes? Who works? When the body senses the sodium is low, what is it going to try to do? Oh, I have to keep it. I have to keep it. And what is it keeping?
Water.
No. When there is hyponatremia, right? Hyponatremia meaning low sodium. When the sodium levels are low in the body, what is the kidney going to think? I should not let any single sodium out of my body now. I have to save it.
Of urine.
Sandeep, you're going in a different direction and I'm not going in that direction. I want you to think in this way. When you have hyponatremia, low sodium means that like the body is going to try to prevent the sodium excretion. So instead of preventing the sodium from excreting, the kidney favors lithium. So that causes lithium toxicity. Kidney has a favor towards lithium. If you study this whole thing, you will understand that. So anytime the kidney is trying to retain the sodium, it ends up retaining lithium. Does that make sense? Because it has a tendency to retain lithium instead of sodium, because they are both +1 ions. The group, does that make sense?
No, I didn't understand.
Okay, this is a very important question and it's gonna come. How does the dehydration connects to lithium toxicity?
Actually, I didn't understand the dehydration. I'm still trying to understand it, like how it is.
Okay, Mandeep.
Even I didn't understand.
Okay, Navjot.
In dehydration, sodium is like retention of sodium is there. Right?
You're telling me. I'm gonna answer in the end because I want to know what you guys understood.
I just due to dehydration, lithium levels increases.
Sorry?
Lithium
How?
as like because kidneys retain the lithium in the body instead of sodium.
Why? But why?
Because you said it's a plus ion. It has tendency
Yeah,
to save
it favors the
It
lithium.
favors lithium.
Yeah. So what happens in dehydration? The body is trying to retain the sodium because sodium will help retaining the water, but instead of retaining sodium, it will retain lithium because kidney favors lithium. I think because of the time, I will talk about this tomorrow, okay? I will explain it in more. Try to understand if it makes sense to you. If no, I am going to explain it tomorrow anyway. But it's a very important topic. That's why whenever there's a player who is on lithium but is playing outside and is dehydrated, he's at a very high risk of lithium toxicity because he's dehydrated. Okay, so I'm gonna cover that tomorrow. I'm just gonna I'm getting text messages from my husband. So I'm just gonna cover the last part. Contraindications, of course, pregnancy and breastfeeding, lithium is contraindicated. Okay. Renal and cardiovascular disease. Is there any confusion about that? Cardiovascular disease, why? Because it will change. What if it's a heart failure, retention of water, right? So that's why, again, if you look at hyponatremia, all those things, you guys will understand that. Dehydrated patients, excessive diarrhea or vomiting. Why? Because it will cause toxicity. Receiving diuretics. Some of the diuretics are increase the lithium toxicity level, like thiazide ACE inhibitors will increase the level of lithium in the body. Okay. Sodium depletion, again, we talked about it, right? Whenever there is a sodium depletion, the body is going to try to protect the sodium, keeping it inside. But what is it doing actually? It's just keeping the lithium now because it likes lithium more than sodium. It's just a process. Lithium and sodium are two same ion concentration, like both of them has one vacancy +1. So that's why the kidney favors the lithium. It's easy for the kidney to retain the lithium instead of retaining sodium. Okay. Hypersensitivity to tartrazine. I don't know this one. I haven't seen this. I will check that. Avoid NSAIDs because NSAIDs decreases the blood flow to the kidneys. and increases the toxicity. Because where should the lithium get excreted from? Kidney. NSAIDs are also, you guys, if you guys remember NSAIDs, indomethacin, you get naproxen, like the Aleve, ibuprofen. Three NSAIDs are there: ibuprofen,
They,
indomethacin,
I
and
remember
naproxen.
they cause
Sorry?
ototoxicity, tinnitus. You asked about tinnitus.
No, that's not what I'm talking about. No, no, that you have to find for tomorrow. But these three drugs, right? These NSAIDs are actually nephrotoxic too. Okay, so something that is nephrotoxic is already causing lithium toxicity anyway. Okay, they decrease the blood flow to the kidneys. If the blood flow is not there to the kidneys, lithium will be inside the body. It will not get eliminated. So education, very important point. Carry ID that shows you're taking lithium. Medical alert banned. Because so much dangerous. What if you're dehydrated and you are sent to the emerge? They need to know you're taking lithium. Okay. Educate on sign and symptoms of toxicity. Educate and stress importance of taking medication regularly because therapeutic range. Serum lithium levels should be checked every 1 to 2 months. I will tell you this tomorrow. They have to be checked every like there is a frequent duration that we check it, but 1 to 2 months is the normal. Once they stabilize, then 1 to 2 months is good. Do not operate heavy machinery. Why? Because they can make you drowsy. Here, nausea, drowsiness, fatigue. Do not operate heavy machinery like in benzodiazepines. Educate on drinking plenty of water to avoid dehydration, therefore avoiding toxicity. Sorry. Avoid starting a low salt diet. Sudden decrease in salt increases lithium. Does that, this is related to hyponatremia. Because what is going to connect everywhere where lithium, sodium was supposed to go? Lithium. Lithium is going to like, oh my God, I have so many rooms to live in because there is no salt. Does that make sense?
Yes.
Hopefully that does. Okay.
Yes.
Lithium is a
I will explain more tomorrow, but please go over them because you have to now make yourself, like I have explained it. Now you have to teach yourself this, that how did this happen? Okay. All right. Next slide was, I just added to this because it's TCAs and MAO and I didn't get a chance to talk about them. Maybe I'm going to be talking about them tomorrow because I am covering all the mental health drugs tomorrow again. When I say again, so the expectation is that you guys will remember a whole lot of stuff. I know it's hard. Mental health drugs are very hard. Okay? They are very hard drugs because it needs not just remembering, it needs a lot of understanding too. Right? So we will cover them tomorrow. I will be covering Alzheimer's first, ADHD, Alzheimer's, alcohol intoxication, and then I have 40 or 50 slides of mental health drugs. Okay, but those are written by me. I have written those slides. These slides I have taken from the book that I keep mentioning. So those slides are a little bit more detailed because I have made those slides myself. Okay, any questions? Are you guys feeling too overwhelmed or something? I'm just gonna stop the recording.